most welcome to this most interesting webinar that Rachel Cook has kindly put together for us. And Rachel, it's so lovely that you could be free to be able to do this webinar. I'll leave you to introduce yourself, okay. But we're really very much looking forward to this webinar on after death and care of the child and family. So over to you. Thank you very much indeed.
Well, I think this is a great opportunity for us all to come together. It's lovely to see some names out there that I'm seeing that I already recognise as part of the Children's Hospital Bereavement Network. So welcome. It's good to see my old colleagues from the hospice where I used to work. So it's one and all, we bring so much wealth, don't we, as children's nurses, to have this discussion. It's not a topic that we often like to discuss. Generally, for those who are working as child death nurses or working in hospices, we're a bit more familiar and in the palliative care field. So I'm going to do a real quick hovercraft as we begin the slides today. I literally, pardon the pun, don't want to kill you off with with slides, but I think it just gives us a capture of death and dying within as children's nurses and what we deal with. And also, I want to have a little bit of time if there's any questions you want to put in the chat along the way that we can address at the end. Because what's rich about us all with our children nurse experience is that we all have different experiences. And the richness of sharing that, I call it cross-fertilization, bringing all different ideas together and thinking, oh, a light bulb moment that's gone off. So I'm learning from you guys as well today. So I hope that we can share at the end. That would be great. So I'm just going to share my slides. And just shout, Ellie, if you can see it when it happens. Is that sharing?
Yes, that's sharing. Thank you ever so much.
Lovely. So like we said, it's about after death care, the child and the family. Just going to... Okay, found it. So I wanted to have a look and talk about all the different environments because some are from hospital, some are working community and hospice. And just appreciate as children's nurses, we cover such a wide, vast area, don't we? For my experience, I've worked in non-governmental groups overseas, in hospice, in hospital, and in the community. So it's a richness that we bring, all of us, our different places. The sad thing is children die, don't they? But unlike the Victorian times, I'm thankful to say that its numbers are reduced. But a recognition that with our speciality and wherever we work, if we work in an accident department, for example, you're going to see a lot of the sudden unexpected deaths that come in. Road traffic accidents. So death and how you see it will be different to the palliative care nurses that do the end-of-life care pathway, often with families. And on a ward, when you get that sudden unexpected death, you might have a child with a metabolic disease and all of a sudden they, the emergency call button goes, and that is a sudden unexpected death. I want to just touch upon as well, I think something I missed in my training in the old days of Florence Nightingale was actually the changes to the body. I think I was quite fearful when I remember taking care of my first, it was an adult, when I did my adult training, first body and the personal care that we did. I was absolutely petrified. And communication with the family and how we support that. One big thing that I want to get you to think about as well for those that work within hospitals is viewings, especially in the time now. We're finding in England and Wales very few paediatric pathologists. So they're coming to big centres for children for their pathology, for them, which brings a whole new level of stress for our families that we work with. So there are changes and things like that are happening currently that has an impact on the grief for families and for staff when you're caring for that family. So I just want to talk about the changes in the body, just so that we have some clarity. that rigor mortis happens 3 to 4 hours. So especially if you're working in the community, and the parents want to stay, in bed with the child for a while, it's just being mindful of that. But it does disappear. And we sent a child home once from the hospital, and one of the things that we go on about a lot is make sure the child is secure. And they did. They put him in a child seat, but unfortunately, that was sitting up. So when they got home, the rigor mortis had set in by the time they got home. So we had to call the funeral directors, and obviously it disappears after 48 hours, the body. So it's where the muscles go quite stiff and they are in that position, wherever you find them. Livor mortis happens minutes, and that is where you get that pigmentation and the colouring. And I think what's really important is to remember, for families, can be quite frightening, because it's where the blood pools. So 20 to 30 minutes after, whatever position the child is lying in, it looks like bruising. It's where the red blood cells drop. So being mindful of that as well, because parents might think, oh, you've dropped them, or there's a bruise. And just by explaining that to families, normally that will go within 2 hours after death. And obviously the change in the temperature of the body. And I think that's what I found quite hard for some families, is to say, no, they're getting cold and wanting to keep the child warm. This is quite a gruesome picture I got here, but I thought it was a good one to just show us. We're really, as children's nurses, we deal, don't we, within minutes and hours after the death. We very rarely see days later, unless we're helping with the viewings and if it's a forensic case. But looking at this, what's really important is the change in the eyes. So the corneal clouding that they get, and it goes like jelly. So that's why it's important when we just shut the eyelids down. And sometimes I often say, if a little child keeps their eyes open, oh, they're peeping at you, just to explain to mum and dad that it's okay. Sometimes the eyelids don't drop down. We don't in this country put coins on our eyes. In other countries, that is a practice that they would do, to weigh the eyelids down, but we don't do that here. So I've explained, just to give you some ideas of the hours of the rigor mortis sets in, and just the change in the pallor and the colour, which can be quite stressful for families. So families are going to have, and I put this slide in, popped it in, because we've finished talking about the changes to the body, is looking at grief reactions. Now, if you were to read this slide, feelings, physical sensations, thoughts, behaviour, we all experience, it doesn't have to be grief, does it? It can be other things, that when the cortisol is released in our bodies and we're stressed, we're going to have some of these things. And so for families, some of these feelings that they get might not be used to. So it's important just to normalize it with them, saying that these are normal reactions that they have. And some of the behaviours, and this might be further down if you're working with the family. For example, if you're a bereavement key worker, you're working with them a bit longer. It's just to reassure them that these things are okay. I love this. This is most of you have seen this if you've done grief training before. This is the dual therapy that we often talk about. And when I talk to parents, I often say it's about the 2 eggs, because nurses sometimes say to me, Rach, the dad, he's not crying. He wants all the job lists to do, and the mum might be just crying. She can't think of what jobs to do, arranging for the funeral directors and things like that. So it's interesting how it doesn't necessarily have to be gender differences, but often one person will be doing the loss orientated, be doing the grief and really finding it painful, while the other person's thinking of the to-do list. And you oscillate between the two. So I call these the 2 eggs. I do my grief work egg and the distraction, the restoration orientation. They call it in dual therapy. This is strobe and shoots for those who want to dig a bit deeper. And what's interesting in the whole years as they navigate their grief, they will do this at different varying degrees. What we don't want is parents to be stuck in one egg or the other. We don't want them to constantly be distracted. but we don't also want them absolutely tearful and can't function doing their grief work. I also love this as a slide for those of you who are perhaps checking in from Ireland. The Irish Childhood Bereavement Network came up for this, and I think this is something that's very visible for us as children's nurses, so that we all as children's nurses are at level 1. We can explain and reassure to the family just the differences, like I mentioned, about the changes in the body, the questioning, and just helping them deal with the child death process that's happening. And a lot of the bereavement key working is in this level 1. Level 2 and 3 is a little bit more about bereavement support, bereavement counselling. And the level 4 is, I often refer on to more therapeutic services like psychotherapy, where they might have suicidal idealization and self-harming. On that little note, most of you would have heard parents say, I don't want to live anymore. And that is despair. It is not suicidal idealization unless they begin to tell you how they're going to do it. So I've mentioned the bereavement key working, and we do this in England and Wales. I'm not sure, I know Scotland have their child death process, but if you're in another country, it is the person, as a children's nurse, as we work with the families post-death care, which is really important. It's having that understanding of what the legal aspects are, the medical certificate cause of death, how the coroner works, how the medical examiner works. And expected versus unexpected deaths, understanding the impact of sudden deaths, sudden unexpected death in childhood. And as bereavement key workers, it's really important to signpost, know what resources are out there, and the signposting onto counselling services. I have found since probably 2010, when I started my bereavement work at Great Ormond Street, is that a lot more people are coming now for counselling. So whereas I might have had 5 families before, I now have a caseload of 30 for counselling. So child death review processes, understanding that whatever country we're in, know what that process is. And I've just put some of the guidance that's out there. We're going to look at those in a little bit more detail. So who is the bereavement key worker? And I know for those who work in HEMONC, the key worker is a completely different role within haematology and oncology, and has been quite difficult for some people realizing that we are actually the navigator, if you like, in helping on the post-death care for the families. So it can be the family's choice. And that can change as well. So they might say, I want Joe Bloggs, but Joe Bloggs is going on annual leave after a week. So who's going to do the key work? And then as long as it's handed over, it can be like a baton in a relay, as long as the parents know. What we're trying to reduce here is multiple agencies contacting the family in post-death, because that can be really stressful for them. An example that we use here is the family liaison sisters on intensive care. So for example, here in our tertiary centre here, we see our majority of our deaths are in intensive care units. Whereas if you might work in a district general hospital, and a lot of your deaths might be in maternity or coming through A&E as well. So I think it's important that wherever you work, knowing who the key worker is going to be. So it's somebody that knows the family. And it is quite hard if you've only just met the family, for example, in an accident department. You might not have met them or have that long-standing relationship. However, if you work in HEMONC, you might have that relationship and that attachment to that family. So often the clinical nurse specialist is a great role because you've worked with that family too. But again, the sudden unexpected death is quite difficult. And in some areas, there's child death nurses that work in our ICBs, our integrated care boards. So the main responsibility of a bereavement key worker is being reliable and ready. And it's always that person who can say, signpost on, coordinate meetings. For example, a parent might have, I always say bereaved parents to remain curious of why their child has died. So often that bereavement medical follow-up with the doctors, where their questions can be asked, because it takes a while for the child death review process to kick in. Sometimes there's a little bit more of an emergency. So we often say 6 to 8 weeks we offer that medical follow-up with the doctors if they want it. And again, the key worker is great to sit in that room, because sometimes questions can be asked outside of the room, and the key worker can bring that into that safe space. But it's also gathering information to be that representation of the bereaved parent at the child death review meeting. And that's really key. So there can be things that were positive practice, questions that they still got unanswered about the whole pathway until the child died. It is being able to put those questions to the child death review, and then either arrange a meeting for the family to meet with specific doctors or the teams to go through it afterwards, or simply it might just be a portrait of the child that the family want to be shared at the child death review meeting, like they would at the coroner's court. So it's being the representative voice for the parents at a professional meeting, and then signposting and supporting the bereaved family. Medical examiners came in, didn't they, in England and Wales, and we've noticed a slight increase into referrals to the coroner since our medical examiner came in. We have a team here. You might just have one medical examiner, but it's important that you get to know who it is within your area. And so they have to agree what is to be written on the medical cause of death certificate. And so they sign it off and send it straight through to the registry office. But if they are a safety mechanism as well for the families. So if the family are not happy with the team that's been looking after their child, they are independent and they're non-coronial, but they can refer, like I said, to the coroners, and they discuss with the coroner, or they direct us to contact the coroner as well. But they can approve the death certification. So the coroners, and I'm just touching on England, Wales. In Scotland, it's different. So I think what is really important to realise is if the cause of death is unknown, generally that's why we refer to the coroner. Or you might have had a operation, for example, and within that 24-hour window, the child has died, whether it be on the operating table. Again, that has to be referred through to the coroner. There is a guide out there for bereaved families, but I think it's, as children's nurses, it's great for us to be informed in our toolbox that we can explain that process to families. What's really hard is on coroners. They might say, I agree to this death certificate being issued, and that's quite simple. Or they might say, I want a post-mortem, an autopsy. And that, again, they have a choice of type of autopsies. Sadly, what families struggle with, the child becomes under the jurisdiction legally, and so the parents don't get choice whether they can have a post-mortem or not. But the coroner will listen to their concerns. So I do think it's important that the coroner is aware, should for religious reasons, for example, they understand that. So a limited post-mortem can be done, for example, can have a scan or keyhole post-mortem. It doesn't have to be, unless it's the cause of death is totally unknown, like a forensic cut down. So these are some of the resources, and I think it's important to know what's out there if you're developing policy and guidelines for your local area. This is the Hospice UK did this, Care After the Death, and that's a lot about care post-death care, which is really important. Some good examples in there, and this is the latest one from 2024 guidance. Caring for a child at the end of life, for Together for Short Lives, that too addresses post-death care. And I love this last resort, multi-faith care for sick and dying children and their families, written by Paul Nash, that used to be the chaplain at Birmingham Children's. We do memory work, and there's quite a lot of evidence-based research out there how impactful doing memory work with families is. But I often have bereaved parents come to see me afterwards and say, Rachel, they came with a baby box and it was a 14-year-old My child was 14 years of age. So I think we have to be mindful of just checking out what we're sharing with the families and what type of memory making they want to do. I know from the Children's Hospital Bereavement Network, they were talking about the Doppler, having the heartbeat recorded and put into a teddy bear. So there's lots of things, and this area is growing. So do share some of your practices, not just only memory boxes, but fingerprints and handprints, cuts of hair. There's lots of things. Share practices so that it helps parents. And what do they want at the end of the day? They might not want a memory box. I think as nurses, and we always want to fix things and make people feel better. And death is really hard because we can't do that. But what we can do is be present with the family. That's a very strong feedback that I get working with bereaved families. These are some of the books that we use. I love Muddles and Puddles. And often parents like to do that with their own child. It's probably around about age, I would say from 5 upwards to about 8, 9, I would use Muddles and Puddles. It's too little for older children as well. We work with a lot of Islamic families, so we will see you again in Jannah, which is really important. It's a bit like the Muddles and Puddles, but it actually explains death. And also, my sister has died, my brother has died by the Princess Grace. And Harvey Hext, and the Sibling Support Group, which is an amazing website that's bereaved siblings that set up this charity, have done some age appropriate when your sister or brother dies, and they have different ages and adolescence ones as well. These are some of the books that we would use, and I love the Claire Shaw one, A Mind Full of Grief. That is for an older child. But Where Are You, Lydia, is about baby loss as well. So it's finding the right. Now, this is an old slide, so forgive me, because those who work in the field of bereavement will know that Winston's Wish has collaborated with Child Bereavement, and they're called Child Bereavement UK. So they brought all their resources together. Child Death Helpline is bereaved parents answer the phone line, and that's hosted by Alderhay Children's Hospital in Liverpool. SANS is a lot around baby loss and stillbirth. The Lullaby Trust has a helpline too for baby loss, and they're very good around sudden unexpected deaths of babies. Grief Encounter. I'm not exhausting the whole list here, by the way. Grief Encounters is great for children's and their chat room, and it's very focused on children online. And they do have local groups, but they're set in North London. There's 2 directories at the centre here. That is, if you're not sure what's in your area, ataloss.org and Good Grief Trust, which they always do the Grief Awareness Week in December. These 2 directories, you put your postcode in, what type of loss, and you'll find out what is local in your area. And those are 2 great resources to know if you're doing bereavement key working. Also, the Child Funeral Charity, you'll know about that. Colourful Coffins support the Child Funeral Charity, but it's knowing what's out there. And now we have the joy of Google and AI that if we put in, will actually signpost us on, won't they, to where we go. So I mentioned the child death overview process, the child death review process. The reason why we have this is to look at what modifiable factors are there in the child's death, of what learning can we take. It's quite hard for families saying, why have we got to teach you and learn through our child's death? So there has to be sensitivity in how we approach this with them. But this is a great guidance that when a child dies, a guide for parents, and I put the one in Scotland at the side. These are leaflets for the families. The NHS England one is hosted by the National Child Mortality Database. For those of you who work in specific areas like palliative care, they've done some great reports for those who have worked in sudden unexpected death teams. The National Child Death Mortality Database collated the data and have been doing reports on this. So they do webinars as well that are free. It's always worth going on their website to see their reports. And obviously in 2018, the Child Death Review Guidance came out in England, which was really key and led on the whole child death review process. So the child dies, and then there's a child death review that is held. If the child dies at the hospital, it'll be held at the hospital or at the local hospital, wherever the child's taken in. And what happens, we notify, as soon as the child dies, we do a Form A, a notification. That goes into the child death overview panel, which is normally housed by the ICB, the local ICB, and some of them have joined. Some of the ICBs have joined here in London, they have. So, for example, here at Gosh, we would send that into North Central London, which have joined with North West London. And they collate all the report forms. They go out to everybody, the team around the child, asking for reports. So you might be asked, if you're a community nurse, being asked to do a report for a child that you take care. And that all gets fed in for the child death review meeting, and that comes back. At the child death review meeting, they anonymise fill a Form C in, which is an analytical form, and that gets fed into the National Child Death Mortality Database. And this is housed by the University of Bristol. And they started this surveillance when we realised, well, way back in about 2010, just as CDOTs were starting, why we were having one of the highest mortality rates within Europe of child deaths. And that's where all that surveillance and scrutiny started. So the child death review meeting, the purpose is to gather all the history, all those reports, the treatment. And again, like I said, it's looking at any modifiable factors that contributed to the child's death or service delivery. And any learning from that should be fed back and close the loop again around a governance audit structure back into the organisation. And also that gets fed in nationally, like I said, at the National Child. So, for example, we noticed there was issues around safety of you remember the blinds that were quite loose. Now you have to clip them to the side, so children will use them as necklaces and strangulation. So it does inform change in practice down the line at the sad cost of the children that we look after. So I'm jumping around a bit here, but I wanted to just look at self-care and emotional labour and the cost of caring when we're working in the field of child death. We talk about hot and cold debriefs. So in the moment, checking if you're on duty with somebody that they're okay and they have somebody to report into. At a later date, you normally do a cold debrief where you look, and it's a very much a reflection process of looking at what worked well, what didn't. But I do like the commemorating one, and I'll explain a little bit more about that commemorating process in a minute. Supervision, self-awareness, reflective journaling. I love these pictures because we often, if we were doing a marathon emotionally, would prepare for it, wouldn't we? And we recover. And I think we need to be mindful when we're working in the field with child death. It might be one child death that you see, it might be multiple. Have a realization of who we are and what we can cope with, and take it to supervision when we're working with these families. I think the impact of emotional labour on us is really multiple, and it has an impact on how emotionally intelligent we are, what our motivations. I often say when we come to work, it doesn't cut off our personal life. We are who we are. So if I had pain at home and a loss at home, I'm going to bring that into the workplace. So it's important having that empathy and self-care and being honest with those in the team, who we're looking after at the moment. Sometimes we don't have that luxury as children's nurses. If you're working in the field of palliative care, it's sometimes, how can I do some admin just to give a break from doing the actual hands-on? So I talked a little bit about commemorating meetings, and it came from, for those who are interested, it's a fantastic book on death talk. It's a systemic family therapy. Glenda Friedman, she was from the UCL, developed this book, and she uses people's talks. And so by using commemorating meetings as a model for all professionals involved in the child's care, I know some psychologists will use this, but it's about bringing all the team in and remembering and everybody talking about the child and the impact that child's had upon their lives. Sometimes that has a more impactful way and satisfying as a children's nurse. I've done all my best, and actually hearing some of the commonalities, how other people's experience of the child, or difficulties it might have been with attachments. So we all have different attachments with the children and parents and families we work with, and it's being mindful of that too. So I talked about the hot and debriefs, but safety nets. So understanding, for example, restorative supervision is a great model. Debriefs, some of you might use Schwartz rounds. I love this lavender duvet days. I didn't come across it until I worked with the American government, USAID, over in Romania. And they used to talk about have a duvet day. And I translated that when I was a manager to lavender days. If a member of staff, for example, had their own personal loss, it's about, can I get a bank staff in? It actually cuts down sickness when people have duvet days. So it's down to manager's discretion. But I think it's something we need to be mindful of, is knowing the staff. Obviously, you can't have 6 duvet days all in a row, but I think it is understanding the stress that we're under. And peer support, there's nothing like peer support and talking to a friend and networks. I love the children's bereavement network that we have in hospitals, because we all get together, and it's not until collectively that we get together do we realise just the impact of our work has and the sharing that goes on. But more than others, I learned a lot about self-awareness. And for example, the Myers-Briggs, your HR department might do it. It's great to know who you are and how you cope in different situations. And I think it's just being mindful of understanding, as some of us are a bit further on, have a little bit more wisdom. But I wish I had Myers-Briggs early on in my training as a nurse, of knowing where my giftings are and how to work as teams. So that's it. I'm going to stop sharing, because I hope you've got 60 million questions for us, or share your experiences. I don't know, Ellie, how you want to manage this. Is hands up or?
Absolutely. I mean, I think that was fantastic. Thank you so much, Rachel. You really guided us through so many different points, and I think it'd be excellent to hand this over to whoever is on the call. If you would feel able to put your camera on, put a question in the chat, a comment. I can see there that Jess Lester, I don't know if you want to put your camera and mic on, Jess, if you'd just like to talk a little bit more about the Swan Song project.
Yeah, sorry, camera's here, but I'm just, yeah, it's not something that I've used. Hi there, everybody. I'm new in Together for Short Lives as a clinical and research lead, but I thank you so much, Rachel, for that session. That was such a wonderful session covering so many aspects. Well done for managing to do that in such a tight, well, not a tight schedule, but you know what I mean. There was so much to cover, so well done. You did a great job there. Thank you. One of my friends has used this charity. I think it's a fairly new charity called the Swan Song Project, and it supports either people who are end of life or those who are bereaved and grieving to create a song to leave a lasting legacy or tribute to their family, so the person who's obviously passed. And I just wanted to add that as well, because I think that would be a really useful thing, especially maybe for those older children or young people to, I know you were sort of addressing the whole memory box baby aspect, so I just thought I'd share it anyway in case anybody thought it would be useful to share onwards. I've no idea much about them, but I just thought I'd share it.
Yes, that's
Thank you again.
fantastic. I get excited at finding out new things, so thank you for
Yeah,
sharing.
that's okay.
Thank you, Jess. And Vivian, I can see you've put a question in the chat. Did you want to just put your mic on and put your camera on if you're able?
Hello. Yeah, it was just a question on the hospital bereavement standards. So I know, like in the sort of neonatal world, you've got the bereavement care pathways, and in the adult world you have as well. But it seems that the children's hospital side of things has gone quite quiet, and I wondered if you knew of any updates to that, or basically. Yeah, so Vivian, the problem we've had is the housing, the home of the standards. So we wrote the children's hospital standards, and then they were taken off the website where they were housed. So we decided at this moment in time we will review them and then we'll upload them, and then we'll have to find a new website because the Child Bereavement UK network, we don't have a website. So it really is about just coming together because there's no money, as we all know. So we don't have a website. So it's who can actually house that website with the standards. But happy, Vivian, to share those standards. And it's linked to the pathway. So we did, Kath Evans was really brilliant. She helped with the SANS, the bereavement SANS one that they did for the neonates. And then we did a sort of a rough pathway of when a child dies, standards for the hospitals. So that's where we are at the moment, under development and under review. Thank you.
Thank you.
Oh, Michelle, thank you. Did you want to put your microphone on and ask your question?
Yes, I'm Michelle from Arrow Park on the Wirral. I think this is something, I work in the acute sector really, and a lot of our, kind of child bereavement cases do come from those sudden unexplained situations. And this is something we're working on at the moment as to how we can try and support nursing staff mostly with not feeling that they have to dive in and do memory making. We've had a lot of feedback, in relation to there is time for this with families, like we're a district general hospital, so children will then be transferred mostly to Alder Hey, our tertiary centre. But I think it's that feeling that people just want to do something, but equally, in a Sudic situation, we shouldn't be doing things such as handprints. And I don't know how other people navigate that and, try to explain the situation or any ideas. Like we have got wool hearts that we've started to maybe give to the family and to the deceased child, and that does seem to help. But it was just any suggestions really, if anyone had any.
I think you're spot on, and I hope somebody else will join in what you do in your hospitals. You've just hit the nail on the head. It's about, as nurses, we're trained, aren't we, to fix it. But just to share, and I'm sure other people can join in and share their experiences, being present. The bereaved parents say to me they remember the nurse that was in the moment, when the resuscitation's just finished, and the trauma of seeing that, or that there'd been an RTO, or the child was found dead and they've come into A&E. It's the meeting strangers as those children nurses in the A&E, and it might feel really uncomfortable. And I think there has to be some trainer support for the team. I love the wooden heart because that is giving something, isn't it? We do the love heart in the pocket. That's simple, the same. So I'd love to hear from others, but that is so common. The Sudic feedback that we get back from parents, people rushing around being busy and then being left alone. But if the nurse can just literally, don't have to find words, but be with them. But I think that has to take a lot of training, doesn't it?
It does. I think that's the case. We've got lots of different variants in, I suppose, experience for staff as well. So some staff are a little bit more, they've had these situations before, but it could be a very junior member of staff that hasn't, and that need to feel like you're doing something, I think, does overwhelm them a little bit.
It does.
But no, we're working on it, so hopefully,
doing a great job by the sound of it. It looks like Louise Cullen. You wanted to respond to that, Louise?
Yeah, hi Michelle. It's a really good question. I'm the educator for the Peds Critical Care and Surgery Network in the North East and North Cumbria. We run a study day on Sudic, and it's multi-agency. And I was a PDD nurse by background in a district general, so I am very much hearing the situation that you've been in. This topic doesn't really sit within our Peds Crit Care and Surgery remit, but because of the educational requests that we had coming through in the region, we thought that this absolutely was a priority to put time to for a training and education provision. And actually some of my other wonderful faculty members are on the call as well, Lisa and Leanne, who've helped us develop the day. We're supported by the Four Lewis charity who come along and teach with us, and we have a parent story at the beginning of the day. Amber, who is one of the for Lewis staff. She's the project manager, but also lost her little boy in the district general that I worked in. And she talks about that and about memory making as well. And we also involve our police officers, and they come as both presenters and participants on that training day. And we've had lots of discussions around memory making, and particularly in SUDIC circumstances. And what our police colleagues have always advised us to do is to speak to the coroner's officer case by case and ask the question, why can't we do memory making? So the police officers have always sort of encouraged us to do that, with the premise that there's only very few circumstances where that shouldn't be possible, even for only the very basics of memory making. But Amber also talks about being involved with that herself as a parent and having the choice around doing that. So some parents won't want to do that and won't want to get involved. It's too difficult for them. But in her circumstance, so taking hand and footprints, and hers was a SUDIC case as well. And they negotiated that with the police officers present and things to be able to do that. But that was done by the nursing staff without Amber, which was done with all very best intentions. And, you know, we've learned from this ourselves that we want to do the best and make things perfect for that scenario. But actually what she said was, she didn't matter that it was perfect. She wanted to do it herself and be involved and have us help her to do that. So that learning has been absolutely invaluable for us, not only as nursing staff still working currently clinically, but taking forward that learning in the region and spreading that to the people that we train, because it's given choice in a completely uncontrollable situation. So, you know, please do encourage your staff to go and ask that question. The coroner's office, it's a really tough one to do. And I think we're working with such a junior workforce now. We've lost that, you know, when I first started many years ago, we would go along with the senior nurse and you would do it together and you would, you know, hold each other's hand through it. And we've kind of lost a little bit of the ability to do that because we've got less experienced staff and we're always so pulled and stretched. But I suppose it's about taking a moment to pause and think, what's the priority in the department right now? And that's probably it. So yeah, so I hope that's helpful. I'm very happy to share the programme for our study day if it would be helpful to you.
Yeah, that would be great. Thank you for that.
Mirror. I'll pop my email address in the chat box.
Thank you.
Thank you, Louise, because we also run a simulation for SUDIC at GOSH. We're always inundated. So it's whoever comes in the room, whether it be doctors, multidisciplinary, doctors, police, social workers, we make the story specific to who's in the room. So it's very small groups we do the simulation with. So it is 8 to 10 people we normally have in the room. But it is, you know, if there's anything older, hey, whether they do any simulation training, because that's a safe place to learn, is it, in a simulation, Louise, like what you run as well. That's phenomenal. Thank you for sharing.
Oh, that's brilliant. And actually, if it's okay, there's a question from, or well, a statement really from Kate, who is working as a district general nurse and is quite frightened in terms of not knowing what to say, Rachel, or, you know, just being so concerned about having to deal with a child death and not knowing quite what to say or how to signpost policies.
That's really great in bringing that up, because I remember when I first came across this, I used to think, I'm not a psychologist, I can't do this. And then when I trained in systemic family therapy, I thought, oh, there's no different language than when I was a children's nurse that we use. And so something I've learned over the years working, because I do a lot of counselling now, bereavement, is parents say to me, Rach, you can never make it worse. So saying the child's name, I'm sorry for the loss of Johnny. And that is just key. And then pick up on the words that they're using, either death, because some families don't like the word death or dying. Some don't like gone to sleep or is rest in peace. I mean, the professionals that write RIP in all the notes, that's another story. But it is the interesting is use the language that the family is using. And sometimes don't use words, but saying I am sorry for your loss, you know, or Johnny's death, or whatever you want to say, and just see what reaction you get by using the word death. I think something in society we need to do a little bit more training that, you know, like the old days using cancer, we used to use CA, or when I worked in the field of HIV, we used to use 1, 2, 3. I think we need in society try and talk about death and dying with families, but I never push it on them. I always see what language they use and use that language.
Oh, that's brilliant. And actually there's been some lovely comments coming through. People are using simulation with students, but also post-registration. There's comments about actually silence can be okay sometimes as well, Rachel. And some offers of support to other members who've been raising some questions. I think we have time for maybe 1 or 2 final questions. Jess.
Hi there. Sorry, it's not actually a question. I was just coming back to that sort of conversation point, and just to highlight, I popped it in the chat, but with Together for Short Lives, there is a sort of conversations with families sort of section and resource. So I've popped it in there with the QR code if anybody did want to link into it to explore that. It might just be helpful for anyone who might feel it they need a little bit more confidence in it, that's all.
Oh, thanks so much, Jess. That's really valuable. And I think a couple of other people have popped some other resources in as well, but your offer there as well. And I think you invited Rachel to make contact with you. So that's really wonderful. We have time for one final question.
Vivian. Just a comment really. I was involved in a baby death yesterday. The mum was asking, how do I tell my 3-year-old? And I think 3-year-olds are a particularly difficult age group, because they're kind of like, they have a little understanding, but not as much as maybe a school age child. And where do you go? And you know, we talked about kind of using, you know, sort of the proper words like they've died, rather than don't use gone to sleep and things like that. And maybe, and just giving some ideas, like it may be, you know, if they're if they have a spiritual belief, they might use heaven, but they also might not. They might use stars in the sky, that when we look in the stars in the sky, and a 3-year-old might understand that. And just giving some different ideas. And then we also gave a couple of books which are supplied by our charity, and so we gave 2 different books. One, they were a little bit difficult because I think 3 is just again tricky, but we gave these 2 books and said, you know, this might be something also that she might come back to it, you know, when she's a little bit older as well. But I also thought, when I gave out these books, actually it might be helpful for the family, because they're very simple books, and you don't know what the effect, you know, of having very simple language for the adults as well. So yeah, that's kind of how we kind of handled it at the time, but it's always a challenge. It is. An older hay, and I know Chabarim UK have the cognitive ages, how they might act out, how to respond to them. So I've got those sheets if anybody wants those sheets, happy to share.
Oh, Jenny.
Thank you. I think just on the back of what you've shared, Vivian, just a reflection, I guess, from my part. One of the most difficult and challenging conversations I've had to have was when a family had asked me to break the news of a sibling's death to their other children. And that just feels it felt like such a a respectful and a wonderful thing to be asked to do, and very honoured to be asked to do that, but also a huge amount of responsibility, knowing that these young people are going to grow up and remember that moment in their lives. And this family didn't speak English, wasn't the first language of the parents, but the children went to school in the UK. And I think that as well, just making sure you're using the right terminology, like you say, and being kind of definitive with what you're saying also really helps. But definitely I don't think anything prepares you for these conversations ever, no matter how experienced you are and how many times you've had those conversations, those experiences. And please don't ever worry about saying the wrong thing, because I don't think you could say the wrong thing in those situations. Just being there for that family is so important, and they will remember that.
Oh, that's really lovely reflection, isn't it, Jenny? Thank you for sharing that.
And yes, please, Rachel, if you don't mind sharing your useful tools, that would be really helpful.
And there's been a couple of requests, Rachel, around some of the resources that you mentioned. And as you may know, the recording and the slides will be available on the Association of British Paediatric Nurses website. Rachel, I was wondering if that, rather than lots of people emailing you, whether you might be able to share something to place there. Would that be helpful?
That's fine. I can share the sheets and we can put it there. I'll send it to Fiona. But please, anybody get hold of me if you need. I'm one of these old-fashioned ones that like to chat through experiences and share.
Excellent. Well, that is really lovely, and thank you all very much indeed. I hope that's been helpful, and we most certainly thank you very much indeed, Rachel. I know personally, and from the comments, absolutely, there's been lots of really helpful tips and tools, and I think, like Jess reflected, you covered an awful lot, but gave us a lot to take away, which is absolutely wonderful. Thank you so much. We're really appreciative of your time. And expertise, I should say, not just your time, but your expertise. Thank you.
Thank you all. Bye.
Thank you.
Bye, everyone. Thank you. Bye-bye.
Thank you.
Thanks.
Thank you.
Rachel, I know that Fiona is also mentioned in the chat as well, but if you wanted to reach out about the Children's Hospital bereavement standards homing, I've popped my email in the chat. I don't know what the process is in terms of Together for Short
We had
Lives.
it with you, Jess, and it was Together for Short Lives took it down.
Oh, I'm so sorry. Okay,
And
I didn't know that.
We didn't know why. So
Oh,
I
okay.
said it would be a good time for us to review and refresh,
Yeah,
and then we can have a chat about where to place them.
fair enough. Yeah, all
Yeah.
right. Sorry about that. Okay,
It's
thank
okay.
you.
I think it's
I'll
sometimes when
find
people have a
out.
clean up and
I'm
they
interested.
think, where's this come from? Because it wasn't owned.